Hi, I'm Dr. John Martin with Ivy Family Health Updates. I'm here with my sister, Dr. Catherine Martin, and my brother, Dr. Edward Martin, and today our special guest is Paul Perito. Paul is a board-certified urologist. He practices in Miami, Florida, where he is a specialist in sexual medicine, and today he's going to talk to us about erectile dysfunction. And Paul, thank you so much for being here today.
Thanks for having me. Appreciate it.
Tell us a little bit about the causes of erectile dysfunction.
Well, the causes are manifold, and truly anything that causes oxidative stress to the vessels of the penis, that would mean anything that is an inflammatory agent to the vessels of the penis can cause erectile dysfunction. And this would include things like diabetes. Probably 10% of the patients that I see have diabetes. Smokers. Smokers is, at least in Miami, at least 30% of my patients are smokers, and they come in with severe erectile dysfunction, hypertension. Any sort of oxidative stress to the vessels will lead to erectile dysfunction. And some people, whether or not they have an oxidative stress, they'll end up with erectile dysfunction because of vascular insufficiency, meaning there's something wrong with the veins. For example, women who have varicose veins. Well, men can have varicose veins in their penis, and this is something that is just genetic, and they end up showing up in my office, and that'll be the first presentation of a vascular insufficiency in these patients. There's also an endocrine-related phenomenon, and those are usually quite rare. And thanks to the endocrinologist, these days I see less and less of that, and they've been taken care of by either their primary care or the endocrinologist.
Okay. So what kind of workup does a patient get before they embark on any treatment course?
It's interesting. I apparently do more implants than anybody in the world, and one of the things that I believe leads to this incredible volume is I give my patients objective-based evidence of why they have this problem. They come in, of course, they'll get a testosterone level. If they have a low libido, they'll get a good physical exam, a good history. But I think the most valuable test is a penile duplex study. And this is a study where we actually are able to look at the arteries and the veins of the penis, and I'll be able to identify exactly where the problem is and then be able to direct the patient to the different therapeutic modalities that are available.
So what are the different treatment options?
Unfortunately, it's a three-tiered system, and there's not much beyond that. But fortunately, all three tiers have a very high patient satisfaction. Everybody's heard of Viagra. It's a PDE5 inhibitor. It's a pill that allows the vessels of the penis to remain dilated. That we are finding with people with severe erectile dysfunction, it doesn't work. Yet, there's an enormous population where they're just reaching the point of erectile dysfunction where it's extremely helpful, and it's safe for almost all patients unless they're using nitrates, meaning the sublingual tablets you use if you have cardiac pain. The second tier would be injection therapy. Now, injections are an injection that you put directly into the penis every time that you're going to have sex. It's a vasoactive substance that allows the vessels to dilate, and this will work for anywhere from, say, 30 minutes to 4 hours.
You put it into the penis.
It's a shot directly into the penis.
Does it hurt?
I can tell you, I've tried it. It does not hurt. Got to try everything my patients do. No, but it does not hurt, and when monitored by a urologist, it's extremely safe. The problem with injection therapy is that there's a very high dropout rate because they don't want to inject every time that they have sex. It can be rather expensive because the medications are somewhat expensive, and the dropout rate's about 80% over 18 months. So then they end up in the third tier, and the third tier would be the penile implant, which hopefully we'll be able to talk about right now.
Absolutely. So this is a surgical procedure with the implant.
Yes. The implant that I have, the implant procedure that I've created is a procedure slightly different than was done in the past, and it's an approach through the area just above the penis called the infrapubic area. And we call it the minimally invasive penile prosthesis. Why? Because in 10 minutes, all of this can be put into your body. This is inside of the penis. These are the cylinders that fill with, in this case, saline. This is inside of the scrotum. You don't see anything. There's a third part that I never describe because it's inconsequential to the patient, but that's the reservoir that allows fluid to go from the reservoir out to the cylinders. So what does this do? It recreates exactly what we used to have. Before, when you wanted to have sex, blood would fill the two cylinders in the penis called the corpus cavernosum. In this case, you pump, and saline fills those cylinders.
Okay.
So when you want to have sex, you pump the pump that's in the scrotum. That'll fill the 2 cylinders, and as you can see, these are the most physiologic duplication or replication of an erection. And when you're done, there's a deflate mechanism above the pump, and you squeeze, and that lets all the fluid go back into the reservoir.
Now, is this one size fits all, or
No.
just an extremely optimistic
I'm
patient? I don't.
And I'm glad you brought that up. This is actually a 22 centimeter, which is one of the larger models, and I use it for demonstration purposes. But the one thing that you need to know is that the longer that you remain impotent without treating yourself, the shorter the penis becomes. And now there's been excellent papers written where we render a guy impotent in a day with a radical prostatectomy. Take his prostate out, he's rendered impotent in 1 day, and then we follow their penis length. And it's called the penile stretch test. And you can lose anywhere from 0.5 to 5 centimeters every 14 months is the most recent paper that I've seen. So that's a significant loss in length. So what I tell my guys, I'll pull their penis out, put it on a penile stretch test, and I'll say, this is what you got. And this is the only question in medicine where 100% of the time they answer it, I'll say, I bet you used to have this much. 100% of the time they say, no, I used to have this much. They always say that. So now what I do is I say, well, if you wait another year, and I push their penis up against their pubic bone, I say, that's where you'll be. But that's truly, you need to start initiating some form of therapy if you're concerned about penile length as soon as erectile dysfunction.
So once you've measured
occurs.
the length, then that's how you decide what size you're going to
Well,
put in?
intraoperatively, we measure the length with a device called a furlough, and every guy, you give them back what they have at that moment.
Okay.
I just wrote a paper where 75% of men will have exactly, when you do a penile stretch test, that's what they'll have post-operatively. So there's some predictive index that we can utilize.
And this is sometimes covered by insurance?
Medicare pays for a penile implant, which I find great. That's it's wonderful. If you're in a pool where you can either have a hip or a penile implant and you're looking to buy insurance, I don't know where you would go, but I know where I would go. But Medicare pays for it. Most private insurances pay for it. Some HMOs pay for it, and then sometimes it depends upon the cause of the impotence, whether or not they cover it.
Great. Well, that's very informative. And Paul, thank you very much.
Thank you
Thanks
very
for
much.
being here.
Thanks for having me.
Thank you.
Thanks. Thank you.